The next question was, how can AI help in GI bleeding? So I looked, first of all, at the ESG position statement on what we expect from AI in the near future. And to be very easy, no mention of bleeding is here. So this was me trying to sort out where to look for. And so I started thinking about the pitfalls in GI bleeding, and especially those pitfalls in where AI could help. So we can remember that we have 3 moments in GI bleeding, which is before, during, and after endoscopy. So before endoscopy, risk scores that we just saw are not so well performing, and in clinical practice are not so well used. We are doing a lot of unnecessary admissions and a lot of unnecessary procedures, and the symptom reporting, both of the patient and sometimes of nurses and of colleagues, is quite subjective. So we don't know the real color of the feces, we don't know if it is real hematokatia, if the feces are formed, and so on. During endoscopy, Forest guides the treatment, but it has a very high inter-observer agreement. And a small bowel capsule in bleeding, I know it's not actually endoscopy, but since it's one of the most interesting applications of AI, I put it here because it is anyway something that we do also in active bleeding, and it's time-consuming and very variable. And after endoscopy, we have difficulties understanding who is at risk of rebleeding, who we can safely discharge, and when do a blood transfusion, and who to do it to. So this is the simplifying patient identification in procedural decision-making and post-endoscopic management. So where is the evidence in AI for all this? Well, we have some small evidence for endoscopic triage and safe discharge, for rebleeding risk, for decision support during endoscopy, for small bowel bleeding, and planning transfusions. So let's have a very quick look at all this evidence. For the pre-endoscopic triage, this is
a view you can have during an ESD, for example. This is dangerous indeed, because you're not seeing what you're doing, and this is really dangerous because you can cause adverse events such as perforation and bleeding, and this is what you may want instead. So an optimized view so that you can be very precise in what you're doing. And this is also applicable to upper GI bleeding endoscopy. We saw before an example of this playbook for the flooded stomach, so you can apply all different techniques to improve your visualization, so optimize the setup, think about patient position, having a protocol for readout, using suction and water and anti-foaming agent. Think about dealing with clots with a retrieval net, or aspirating them outside the patient. Think about field housekeeping and source-specific tactics for variceal and duodenal bleeding, and convert triggers for intubation or escalation to interventional radiology. This is an example of strategy to improve visualization through clot removal. So there is a large ulcer. We see is actively bleeding, but we cannot see the actual source of bleeding.
So this is an 80-year-old patient who we are following up because of Barrett's esophagus. Maximum extent was C2, M4, and last year it was low-grade dysplasia several times. And this year's follow-up showed high-grade dysplasia in 2 areas that was confirmed on the second read of pathology. And today he was scheduled for a planned treatment of these dysplastic areas.
So it's fair to say David marked the area, and we did a cap and snare resection, or he did a cap and snare resection. And after his first piece, we had a little bit of bleeding from the edge, and we thought, great, we've got something to show you guys. And he came to do the second piece, and I turned around to the guys and I said, when he removes this, the bleeding may well stop. And of course it did. And then we didn't have any further bleeding following the resection. So it's a beautiful resection, but it didn't help because we wanted to show you guys some bleeding. But given there's no active bleeding, what we're going to do is maybe show you the vessels, what they look like in white light. Then we're going to use a color filter, which in this system, the Olympus system, is called RDI, which highlights the blood vessels in an orange color. It gives you a nice calm feeling if there's active bleeding. And then what it does is it blunts the background imaging such that if you do have an active bleeding point, it helps you identify the bleeding point easier because it suppresses the red, sort of the red mass that you get. So this is a normal white light picture. You can appreciate you're looking at the submucosa. You've got some slightly larger and smaller vessels coursing through it. And of course, we can look at the vessels and you've got to think, well, are they arterial or venous? Do they have pulsation? And probably the most important thing is the diameter, David?
I think so. So I think you can see here what sort of views you can get just with a tangent with a cap. All right. So you have a cap. You have high definition endoscope. So multiple speakers in the previous session talked about that. And you have then water, and the patient's intubated, so we're in a safe situation. And you can see beautifully the blood vessels. You can see what they look like, and maybe if we can show them a cut-ended blood vessel. I'm trying to really demonstrate to you why is he doing a resection. He's in a basic endoscopy symposium. He's done a huge esophageal resection. But the point is to show you what a blood vessel in an upper GI will look like. And Andrea has just shown you some nice examples, but probably here we can find what you're looking for in your upper GI bleeding.
Center of the field.
Yeah, something like that is probably what the sort of thing that you might find in an ulcer in upper GI bleeding, right? Now the difference here, of course, is that the tissue is compliant, right? So that changes what we do?
Absolutely changes what we do. So what you can see here is you've got a vessel coursing just sort of up and left to the center of the screen. And the vessel comes in from the left-hand side and then heads north. And what David has done as he's cut through is he's tangentially cut across the vessel. So you've effectively de-roofed the vessel. And you've got the vessel, the defect, the red defect in the middle is slightly less than the diameter, but it has quickly clotted off, which is why we're not getting a stream here. The point about compliance is if you haven't got any compliance and you're in a bleeding situation and you're trying to apply a clip, the clip will not engage the tissue and may well tear the tissue and is unlikely to be able to grasp around the vessel. So you need to think about your strategy depending on tissue compliance, but also the vessel size. So for a very small vessel like this, as David's going to demonstrate, we're going to just apply direct heat with a little bit of pressure and it will seal the vessel. And this is also true if the vessel is sitting in the bottom of a base of an ulcer. And actually thermal energy in that situation is actually very effective. And possibly,
if you can't control the bleeding, this is also a reason to call your interventional radiologist, maybe a bit more urgently. This is a reason for salvage tips. This takes a few hours or a few days, depending on the center where you work in. So you need a bridge to the tips then. This can be a balloon tamponade, but maybe nowadays it's better to put a self-expandable metal stent. And before you call your interventional radiologist, not every cirrhosis patient it's necessary to put a salvage stent. Necessary, I mean, sometimes it's futile care. If the liver function is very poor, CHOP-UC 14, 15, a high MELD score, a lactate more than 12, unless there's a liver transplantation envisaged in short term, this can be futile care. So think about this with every patient. So you're in between the tips. You can place a balloon tamponade. This exists for a very long time. Can only stay in place for 24 hours. You want to desufflate this from time to time to avoid necrosis. We have the self-expandable metal stent now. This is placed without X-ray. This is more efficacious as a balloon tamponade and also a safer option. Controls the bleeding very well. Can stay in position also longer, 7 days, 5 to 14 maximum. But there's also a bridge to that salvage tips.